A very good evening to one and all. I, Dr. Kesha Jani from IIP Digital Media team will be hosting this webinar on advanced physiotherapy management of long COVID patients. The resource person for this webinar is Dr. Seema Grover. It is being organized by IIP North Delhi District. We are streaming live on IIP India YouTube channel. I request all the participants to kindly subscribe to this channel to receive regular notifications during our webinars. You can also follow IIP social media pages on Twitter, Facebook, Instagram, LinkedIn for updates. Now, I shall hand over to our moderator, Dr. Shivani Sharma. Shivani ma'am, over to you. Thank you.
Good evening, everyone. Myself, Dr. Shivani Sharma, Executive Member of Delhi IIP North District team. Topic of today's webinar is Advanced Physiotherapy Management of Long COVID Patients. My special thanks to our resource person, Dr. Seema Grover. She is MPT Ortho, a certified lymphoedema therapist from USA, postgraduate in rehabilitation and geriatric care, former HOD of Badra Hospital, Delhi, and now currently she is Chief Physiotherapist in Apollo Hospital, and she is also Joint Secretary of Delhi IIP. I would like to thank Dr. Sanjeev Jha, President of IIP, Dr. Ruchi Vashne ma'am, Treasurer of IIP, Dr. Pooja Sethi ma'am, President of Delhi IIP, Dr. Zubia ma'am, Secretary of Delhi IIP. Now I also like to thank my friends of North District IIP team for organizing this webinar. Dr. Sumit Saxena, convener of North Delhi IIP, Dr. Bharat Gupta, Dr. Sadeshu Srivastava, Dr. Ashwani, Dr. Ashish Jindal. Now I request everyone, please mute yourself, and the question answer session will be at the end of this webinar. Between the webinar, no question answer session is there. Please ask your question after the ma'am's presentation. Dr. Seema, you can start now.
At the outset, I would like to thank team IIP country, team IIP Delhi and North Delhi branch for having me here for the webinar during this physiotherapy week, what we all are celebrating. My screen is here. Can it be seen?
Visible, ma'am.
Okay. Thank you, everyone. So today I'm going to talk about physiotherapy management in long COVID. We all know that there is a re-emergence of new mutants which have come. This wave is still continuing. But because of the mutation, now there are various questions. We find that these patients are still on, and the burden on these patients of having this long-term sequel is also going to be there. So it is expected that it may produce another public health crisis on this current pandemic. So I believe the thought process of WCPT or World Physiotherapy, Delhi IIP, having the theme long COVID and physiotherapy is so apt that it's really, really important that we all should be aware of the clinical manifestations, what are the risk predictors, and what is the holistic management approach. It's really critical to evaluate what will be these long-term or what are these long-term sequences, what we all are facing these days. And we must plan our post-physiotherapy, post-COVID, this physiotherapy care accordingly. So having the topic about physiotherapy management in long COVID, I would, thanks for the introduction, Dr. Shivani and the whole team. I would like to put it, we all know what is COVID-19. It's a global pandemic, which was said in 2020, and an infectious disease which is caused by severe acute respiratory syndrome, coronavirus 2. We all know the transmission is mainly through contact, droplets, aerosol, fomites, and even certain studies that talk of fecal-oral route. So if we talk of COVID, then we tell it as mild when the symptoms, there is onset of symptoms. Within 5-6 days, what we see when we get our RT-PCR done, then we get to know And thereafter, the recovery is within 2 weeks. But the symptoms are said to be severe when the recovery takes little long or even longer. But what we are finding these days, that these people are even coming up with symptoms even after 12 weeks. So the theme came as long colors or long COVID. If we talk about the statistics on the global and the Indian level, globally, the confirmed cases is 222 million, which is the latest data, and 4.6 million deaths have happened till now. And now also we are finding that the new cases are coming 4.5 million per week, if we talk of last 4 weeks. But at the same time, we know that 5.35 billion cumulative doses of vaccines have been administered globally. Now, when we talk of Indian scenario, the active cases are still going on, which is 3,91,000 as on today. Deaths are around 4,42,317. But what we see is a lot of vaccination has been done. When we talk of long COVID, we know that 50% or 10 to 30% of these patients will come up with some symptoms, and we call them as long COVID or long haulers. Those symptoms are initially also what they were found in the beginning, and on the follow-up, mainly is fatigue, dyspnea, joint pain, chest pain, cough, rhinitis, and various other symptoms which were showed in the beginning, and now also it is seen. If we talk of the term long COVID, the signs and symptoms that develop during or following an infection of COVID-19, which continue for more than 12 weeks and are not explained by any other alternative diagnosis. It usually presents with a cluster of symptoms, often overlapping, which can fluctuate and change over time and can affect any system of the body. So it's really, really important that this huge burden, how the globe will handle. And we as physiotherapists maybe are, or definitely are, the torch bearers in it, because now with the COVID, people have really, really understood what is the importance of physiotherapy throughout the continuum of care. So if we talk of predictors or risk factors, people who had COVID, those who are elderly, they are at risk to have long COVID symptoms. People who had abnormal lab values, or those who have underlying comorbidities like diabetes, hypertension, obesity, any other CVDs, smoking, alcoholism, or kidney disease, or people who had a long length of stay in ICU. Other factors where we say those symptoms, what I just spoke in the beginning, 5 or more symptoms during first week of infection if they had. And it is found that in these studies now it is women who are more vulnerable to have long COVID symptoms. In this slide, I just wanted to put one thing, that I believe COVID has left no system affected. So here we see its endocrine system, heart, or all our muscular system, brain, the neurological, even the urogynecological, eyes, our kidneys, as I said, even the skin and GI. All the systems have been affected by COVID-19 infection in various forms. It is manifesting. So what are the clinical manifestations of long COVID, which we are talking about today? If we talk of neurological symptoms, then it is brain fogging or not being clear or unable to really think the way a person was. Or there is persistent loss of smell and taste, encephalopathy, stroke, various other symptoms also, which are post-ICU, neuropathy, myopathies. All those symptoms are also seen in long COVID. If we talk of pulmonary, of course, dyspnea and cough, which were the initial symptoms, are also persistent in people, and various other interstitial lung disease kind of symptoms are also seen. Even it has not left skin or cutaneous system, where the rash is quite common and what we call as COVID toes. So psychiatric, if we talk of depression, post-traumatic stress disorder, anxiety. Of course, social isolation has taken a big toll on people during the lockdowns. And thereafter, in cardiovascular system, I'll be talking further that how these symptoms are shown or manifested and how physiotherapy is going to be helpful. Talking of joints, which is fatigue, myalgia, neuropathies, are all the symptoms which are common clinical manifestations. So when, as a physiotherapist, if a patient comes to us, then what we should be really doing is, first of all, taking a detailed history. That what is the COVID history, when did it happen, what were the symptoms there, is there a hospitalization history or not, are there any comorbidities when the person is hospitalized prior, is there any limitation at this moment to return to the previous activity of level, post intubation, did they have any complications, after discharge or during the stay in the organization in any hospital, did they have any sleep disturbances or swallowing concerns, what exactly are the vitals now, and when they are coming to us, do they really feel alteration in their vitals very often, is there any dyspnea or rate of perceived exertion, what they can really feel, how is their breathing pattern, what is their posture, if there is cough, then we must auscultate and see what area is the involved area, is the person for breathing using any accessory muscles, or there is current any oxygen requirement, because many patients have gone home on oxygen therapy or supplemental oxygen, and what exactly is the functional capacity of a person, the person who's come for the assessment, and what is the level of physical function. So this detailed assessment is going to really guide us how we should proceed further. When we talk of assessment, then definitely if we need to measure it objectively or quantitatively, then certain outcome measures are mandatory on which I examine the day one, and whenever I examine the day two or reassess if I find a change. So these outcome measures, as it is shown in the previous slide, that fatigue is the major component. So using various fatigue scales, one can really see that what is the level of fatigue. Fatigue severity scale or VAS-F is also there. Similarly, many of the patients, they come with the complaint of feeling weak, unable to walk or do their activities. So their strength testing, MRC scale or sit to stand 30-second scale, again is going to talk about that. In MRC scale, we talk of the three major muscles of upper extremity, three major muscles of lower extremity, which is like deltoid, elbow flexion, wrist extension, and talking of hip flexors, knee extensors, and dorsiflexors. And we grade it from, again, 1 to 5, and we say where we are. And in this sit to stand 30-second test, we see that how many times a person is able to get up and sit for 30 seconds. There is a normative data with which, according to the age, we can gauge the muscle strength. Again, balance testing is equally important. So using the scale as Berg balance or time up and go or short physical battery test, and functional gait assessment is also needed, where we can talk of that what exactly is hindering or making it difficult for the person's balance. Talking of endurance, as I said, talking of functional capacity, so it can be done by 2-minute walk test or the standard 6-minute walk test, which is gold standard 2-minute step test. So again, finding their metabolic equivalent level, that what is their VO2 max and how much can they really work. So it is important. Knowing about the core strength of a person, that what exactly is the strength of the core, knowing about diaphragmatic mobility, its strength and endurance, knowing about can a person can really do incentive spirometer, that can be outcome measure too. Volumetric spirometer, you can see that what was the level in the beginning and what is the level when we reassess. What is the spinal range of motion? Are there any limitations? And definitely screen about DVT, deep vein thrombosis, because we hear quite often pulmonary embolism is one of the causes of sudden deaths post-COVID. And along with that, all the more which has been hampered is quality of life. So through various scales, we can grade the quality of life. Here I've just put modified walk dyspnea scale, where working on patients' dyspnea is equally important, that how much is this scoring and where it is leading us to. At the same time, in physiotherapy, it is very, very important that we must assess posture of every patient who's coming to us. So is it something like developed now upper cross syndrome? Because we've not to forget that it is post 12 weeks, they're coming with the symptoms. So a very, very thorough assessment is going to lead that what program or plan of care we should have for the patient. So knowing that is the patient having forward head posture, or there is any cervical, thoracic, lumbar alignment concerns, any other spinal issues like scoliosis, kyphosis, or there is hypertrophy or accessory muscles. Along with that, what is being noticed these days is autonomic dysfunction. Many of the patients, they are complaining of dysautonomia, which is postural tachycardia syndrome, POTS, where if somebody just gets up, one may have the heart rate really pacing, which may be maybe 20 or 30 than the resting heart rate in number change. So if it is so, one has to be very, very careful, because it is that autonomic dysfunction or the anaerobic concern. So knowing about this abnormal vital response, that there is change in the heart rate, which is so rapid, maybe the blood pressure also fluctuates. So we need to know that oxygen saturation up to 94% is somewhere good, necessary. Similarly, as I said, your pulse rate, whatever, suppose you are a little high, 80, 90, for people, adults, it is if 30 beats more, then one has to be cautious. For little younger lot, by age of 70, adolescents, then it is 40 beats. If it is higher, then we should look into it. Similarly, about their blood pressure, similarly about their saturation. Is there anything along like they feel nauseated, vomiting, sweat, cramps, shortness of breath, or palpitations? We must make an account of it into our thorough assessment. At the same time, are there any cognitive concerns? So, is there any memory concern? Or are they feeling, as I said, even brain fog? Are they feeling certain other concerns? So, if one has to test for which is postural tachycardia syndrome, that tilt table test is one of the things where a patient's BP heart rate is taken in line, then 60 to 70 degrees on tilt table it is taken, and then put it for a while and then taken again. And if we find these features, what I have discussed, then one can put it as some autonomic dysfunction. Another very, very major chunk of people, what they are finding is fatigue, which these days is also known as PEM or post-exertional malaise or chronic fatigue syndrome. We all definitely know about fatigue. In Hindi, we say thakan. But most consistent and most persistent symptoms people experience is triggered by some exertion, maybe little exertion. And then these symptoms are triggered, which can be something like aches and pains, something like reduced physical activity. They find reduction in their functional capability or cognitive function, or worry, anxiety, depression. Even their social and personal relations, they find the changes coming. And when it is triggered through very slight exertion, maybe that tomorrow I have to go for the doctor's appointment, and suddenly palpitation, these symptoms, they just come up. So one has to really understand that how do I really manage? One very important thing which is talked about is pacing, that I pace with my symptoms. I think that how much can I grade my activity at this moment to be? So that is to be individualized. One, people who are with chronic fatigue syndrome, they can make a diary, they can keep the record that when, with what activity, what happened, what were the symptoms, and how do I get relief. Then they can gradually get to know that which all things really put them to that trouble. So, to begin with, the answer to this chronic fatigue syndrome can be resting, maybe having a better sleep, a good nourishment, and gradual mobility, starting with very low activity, maybe in bed activity, and then allow time to do things further. Gradually, once the things are into order and one feels that I can manage my symptoms for some time, then we work on core strengthening. We educate patient on better hydration, and we can start on the recumbent exercises. Once that stage is also crossed, the person can go for interval or circuit training. But very, very important is that throughout each change in activity, we must monitor vitals and dyspnea. Very much talked about these days is post-intensive care syndrome. Many people who have been through COVID and have long time intensive care stay, they generally are coming up with these impairments. In post-intensive care syndrome, most of the impairments which are seen are physical, which can be something like ICU acquired weakness, neuromyopathy, sarcopenia, osteoporosis. Psychosocial, where cognitive, memory function, execution, and post-traumatic stress syndrome or anxiety are found between 20 to 57% of the population, and certain mental issues from 6 to 60% of the population. Another important impairment is social, which is during their stay or otherwise, they have been in isolation and they have not been able to meet their people in the society or be as before in the society. All this has been found to affect their functional capacity, even to the level their activities of daily living and their muscle strength. So, as previously discussed, we would look if we find a patient coming under this syndrome, then definitely outcome measures have to be put during assessment, which may be 6-minute walk test. One can look for grip strength or look for MRC score. For ADLs and independent ADLs, we can go for functional independent measure or Barthel index. And when working for mental distinct, mini mental score we can work for. Another important thing to know that how we should rule out the DVT, which is happening to these people or person landing with pulmonary embolism. So there is a score by the name Wells score criteria, which talks of certain points. And if a person is having persistent tachycardia and positive D dimers are there, and there is unilateral swelling, if the person has come to your facility or clinic, then definitely we should think that do we really need to check its Wells score? Because if on Wells score, if your score is less than 4 and your D dimers are less than 1000, then it is unlikely that one would have PE. One can go ahead irrespective that one has unilateral swelling. Or as I said, many, many systems are involved. So it can be some other system involved. It can be a renal concern where bilateral swelling is there. But in our facility, we have seen patients who have come with bilateral swelling, but at the same time, one leg is more swollen than others. We all do Homans, but in these cases, if we use this Wells score criteria, we can definitely work on it, that how or where do I put this patient? Do I really need to send for further investigation? Maybe something like ultrasound or something, or I can manage on my own in my facility. So when we have to plan the management for long COVID, we need to remember 4 P's. First is for pacing, which I just spoke in length, that one has to manage one's own activity. Then is planning. When we are doing so much of battery of tests, then we can definitely plan that how am I going to manage my patient. Next piece for prioritizing, that I really prioritize because it is multi-system involvement. There are more than 5 symptoms what you would find. So you need to prioritize how you would manage them. And at the same time, very, very important is precautions. I believe even CDC or everybody, the bodies which are working for maybe Ministry of Health and Family Welfare, maybe CDC in America, maybe Australian, all bodies, they really, really talk about precautions, which is nothing but using proper PPE, maintaining the distance of 6 feet. Somewhere they have spoken, one can work with 1 meter in their general facilities, but at the same time, wearing mask is a mandate. So whenever we plan to manage long COVID, we must remember these 4 P's. One has to make individualized plan of care. When one is doing so much of assessment, you will find each and every person with little different kind of symptoms coming, which may change here and there during their care also. But in general, if I talk of the intensity or how much or what exercises one should do, when we talk of cardiac rehab, then it is aerobic exercises, which should be sub-maximal intensity, which is one can start with 40% and gradually build it up, and 3 to 5 times per week, along with resistance training or circuit training, which is again moderate intensity one should go, which is 8 to 12 repetition maximum, and 2 to 3 times a week only. When we talk of respiratory rehab, inspiratory muscle training, thoracic expansion exercises, airway clearance, and PEP devices, when hemodynamically one is stable, one does not have acute respiratory distress, because otherwise it's going to be really troublesome. And as I said, all these respiratory rehab, it is mandated that proper PPE is used to avoid transmission. Along with that, I would like to put that with every activity or exercise, whatever we give, we must emphasize diaphragm. We all very well know that diaphragm is a primary inspiratory muscle. It is also a core stabilizer, and it also works as anti-reflux. So how important it is to work on the diaphragm, because when the diaphragm is weak, we know there is increased, all these things can lead to diaphragm weakness, which is something like when we are in an awkward posture, when we have immobility, when we have mechanical weakness, or there is increased work of breathing. Whenever, if we find somebody coming to us is using more accessory muscles, then we understand that we really need to emphasize the diaphragm. Whenever there is altered breathing pattern, or overall there is reduced activity, or we find there is reduced intrathoracic and intra-abdominal pressure. So it is really mandatory that with all activities, what we make the person do, or the exercise, we must emphasize diaphragmatic breathing and remember the diaphragm in all our activities. I would like to put it that when we talk of multi-system involvement, when we talk of exercises so much at length, then I thought of putting this to everybody. When we talk of long haulers, then what is the potential benefit of exercise? When we talk of psychological, then we know it modulates pain, it improves well-being and mood state, and decreases stress. We know exercise releases various good or happy hormones, so which has that effect on us. Neurological effect of exercise, it increased neurocognitive abilities, decreased cognitive dysfunction, and increased sleep quality. When we talk of cardiovascular symptoms, what we see, but our exercises, what they do, they increase mitochondrial biogenesis, they increase the cardiovascular function, decrease blood pressure, And definitely exercises when given in graded form with regular vitals check, it normalizes dysautonomia. In respiratory features, exercises would definitely reduce dyspnea, will increase our oxygen uptake, so will improve our pulmonary function. And also, when we talk of the musculoskeletal system or myalgias or sarcopenia or osteoporosis, we all know exercise improve muscle mass, increase strength, increase intermuscular coordination, and our tolerance to or the capacity to perform. And when we talk of immune system, we all know that exercise have anti-inflammatory cytokine effect. It reduces the pro-inflammatory cytokines and it improves the immune function. It reduces the immune death of the cell. So we can see a gamut of or a galaxy of benefits exercise can give during this post-COVID syndrome. I'm coming to the end of my talk, so I would like to summarize this whole thing that this multi-systemic therapy for long haulers is necessary due to the diversity of their cases and symptoms. As I talked about, that symptoms can change in between also. And we need to use the clinical, investigative, and therapeutic tool to manage it optimally and efficiently. Definitely, tailored optimum exercise prescription would benefit individuals with persistent COVID-19 symptoms, and all efforts to enable a complete functional recovery and a return to previous life should be done and can be done. When we are so objectively measuring everything, we can definitely enable them to their complete, available, or optimize their functional recovery. Over and above, it is really, really important. It is seen that lifestyle modification and general preventive measures like social distancing, hand hygiene, wearing a mask are really, really important, and they have been said to be mandatory. I would put it as silver lining in the dark cloud, telephysiotherapy. We know COVID-19 has changed so much for all of us, the way of working, the coming of patients to our clinics, to our hospitals, the lot of cost and so many things, talking, listening about our near and dear ones, where we were able to go for home visits, we are not able to go, we are not able to have people on our clinic. So what it has done now, COVID-19 can be seen as a springboard for positive change, as learning to function in digital form and provide virtual interventions to optimize patients' symptoms, self-management, independence, and social participation. So we all have learned, though early, I would say, very early, immediately after COVID first wave, we all were into online or virtual platforms for virtual interventions. We at Indraprastha Apollo Hospital on this 8th September, on World Physiotherapy Day, we had an activity where we did a lot of assessment for all our patients, and we had put the theme "An Answer to Long COVID." So I just wanted to share that how important physiotherapy is when we talk of long COVID. Thank you, everyone.
Thank you, ma'am. Thank you so much. Ma'am, there are some questions from the participants. Can I ask?
Sure.
Yeah. What are the precautions for the long COVID patients we should take even after recovery?
Sorry, what are the precautions we should take?
Yeah, after long COVID recovery.
See, as I said, there is no doubt that we should be implementing mask mandate. We lose our guards, we all walk with our mask down below, but for sure, something WHO has made something like 3 C's: avoid crowding, avoid being in congested areas. So proper ventilation is equally important. wearing your mask is a mandate, and avoid crowding and maintain a distance of 1 to 1.5 meters, if not 6 feet, is a mandatory to avoid. At the same time, having good activity, having good nutrition, and a total multifactorial approach should work, because we found certain people having swallowing concerns. So with physiotherapists, occupational therapists, maybe speech language therapists, they all can be together working on the same. So various things, or psychological concerns, we can have a psychologist along. So we got to know, I believe we got to know the importance of multidisciplinary team approach also during this COVID. So the main thing would be, again, having proper protection.
Yes, ma'am. The next question is, what are the extra precautions for the diabetic, hypertension, and the cardiac patients?
See, as I said, people who are with comorbidities, they have to be very careful. They have to be monitored very closely. If they talk of any symptoms, because they are the vulnerable lot, they are more prone to have certain features. So it is very, very important that their features or their manifestations should be really documented and charted. They should maintain a diary. They should be gradually going on to activity and maintaining as much physical activity as they can, but under supervision of a physiotherapist.
Ma'am, what are the extra precautions for the senior citizen persons?
We have seen vaccination has played a big role. So in my initial slide, when I talk of statistics, we saw that, and in the second wave also we have seen, and in the coming wave also we are seeing in various parts of the world, it's already the third wave. We have seen those people who are already vaccinated, even if they have COVID, the intensity or the symptoms what one gets with the COVID are very little. So vaccination would be mainstay, I would say that people should think of vaccination. They should, those all who are vaccinated with only one go, they should be vaccinated the second time, because there are studies which are talking of hybrid immunity, that post vaccination they're developing immunity, which is very, very good. And definitely it will reduce the risk of long COVID symptoms.
Thank you, ma'am. Thank you so much. Thank you so much for sharing your experience with us and increasing our knowledge. Now, I'm thanking all attendees and our resource person for this arranging this presentation. Thank you once again for the everyone, and we will come again with a valuable webinar and bringing you with more informations. Thank you, everyone.
Thank you.